The chronic stable angina, it is also called ischemic heart disease. So what is the definition of it? These are heterogeneous group of disorders. Okay, and mainly this ischemic heart disease or the chronic stable angina occurs mainly due to the mismatch between the myocardial oxygen supply and the demand. So whenever there is a high demand for oxygen, but there is no that much myocardial oxygen supply is not there. So there is a mismatch between those. Then this will leads to this ischemic heart disease, and there are stable ischemic heart disease there and also unstable is there. Stable ischemic heart disease, then there will be chronic stable angina. We call it as chronic stable angina, and in severe condition it will lead to acute coronary syndromes, that is unstable angina. Okay, there the end STEMI and the STEMI comes here. Okay, so okay, that's it. So then why does the ischemia happens here? So mainly we should know the circulation, that is our myocardium is perfused by the coronary circulation, that is by the macro circulation and micro circulation. And here the macro circulation is by the epicardial coronary arteries and micro circulation is by the small arteries and arterioles and the capillaries. Okay, so these are the micro circulation and macro circulation. And in this figure you can see this one is the macro circulation, that is the epicardial arteries which are greater than 400 micrometer, and these are the small arteries which is less than 400 micrometer, and these are the arterioles less than 100 micrometer, and last the capillaries which is like less than 10 micrometer. Okay, so this is the circulation, this is the circulation of the myocardium. Okay, and in this circulation the maximum resistance to the blood flow is mainly provided by the arterioles. Okay, so whenever the demand increases, the blood supply also increases. Okay, and here the epicardial coronary artery may predispose to, okay, which is the artery which is more predisposed to atherosclerosis, then it is the epicardial coronary artery is more predisposed to atherosclerosis. Okay, so I told now whenever the demand increases, blood supply increases. How that is happening? That is happening by the micro circulation. That is the micro circulation, small arteries, arterioles and capillaries are capable of changing its diameter. Okay, especially the arteries has the capability of changing its diameter. Therefore, it can this will help in the myocardium when there is a demand for the oxygen, like exercising time. Okay, so the arterioles will increase the diameter and helps in that conditions. So next is the mechanism of the myocardial ischemia. So this myocardial ischemia may occur due to the involvement of the epicardial coronary arteries or due to the coronary microcirculation involvement. Okay, so in myocardial, okay, in epicardial coronary arteries, maybe there is an atherosclerosis disease or there may be a vasospastic disease occurring. Okay. Okay, so these atherosclerotic diseases that is affecting the vessels, the atherosclerotic disease that affecting the vessels may be a stable plaque or a vulnerable plaque. If it is a stable plaque, this will reduce the coronary flow rate. It will reduce the coronary flow rate. If it is a stable plaque, it will reduce the coronary flow rate and it will resulting in the angina episodes, because there will be a demand for the blood and this will leads to ischemia and leads to angina episodes. Okay, that is about the stable plaque. And if it is a vulnerable plaque, it will predispose to rupture. Okay, the plaque rupture occurs, and if there is a plaque rupture, this leads to thrombosis and this leads to the acute coronary syndromes or the infractions. Okay, here angina episodes and here acute coronary syndrome or infraction occurs here. And in case of vasospastic diseases affecting the vessels, there may be focal ആയിട്ടുള്ള transient vasospasm കാണാം or persistent vasospasm കാണാം. Okay, transient കാണാം, persistent കാണാം. In case of transient vasospasm, that is called this leads to Prince metal angina, that is due to the transient vasospasm, and persistent vasospasm will lead to the MI. Okay, MI. So these are the epicardial coronary arteries involvement, atherosclerotic and vasospastic diseases. And in case of coronary microcirculation also there. Okay, so we discussed about the macro circulation, and somehow the coronary microcirculation also result in this mechanism. That is, the changes happen here are either due to the structural mechanisms. Okay, structural mechanisms that will affect the primary macro circulation, or it can be some myocardial factors that is affecting the microvascular function, or it can be due to some functional mechanism. So in case of coronary microcirculation, it can be some structural mechanisms, myocardial factors affecting, or functional mechanisms. So what are the structural mechanisms? Can you say what are the structural mechanisms? That is the increased medial wall thickness, intimal thickening, reduced wall or lumen ratio. Okay, these are the structural mechanisms. ഓക്കെ, അപ്പോൾ സ്ട്രക്ചറൽ മെക്കാനിസംസ് എന്ന് പറയുമ്പോൾ മെയിൻലി നമ്മുടെ ആർട്ടറീസിലെ വോളിൽ ഇപ്പം ഇന്റിമയാണെങ്കിൽ ഇന്റിമൽ തിക്കനിങ് കൂടുന്നത്. ഓക്കെ, അതുപോലെ തന്നെ മീഡിയൽ വോളിന്റെ തിക്നെസ് കൂടുന്നത്, ഇൻക്രീസ്ഡ് മീഡിയൽ വോൾ തിക്നെസ്, ഇന്റിമൽ തിക്നെസ് കൂടുന്നത്, അതുവഴി റെഡ്യൂസ്ഡ് ദി വോൾ ലൂമൻ റേഷ്യോ കുറയുന്നത്. ഓക്കെ, വോൾ ലൂമൻ റേഷ്യോ ഈസ് reducing. So these are the structural mechanisms which is leading to this microvascular dysfunction. Okay, in next one is the myocardial factors which is affecting the microvascular functions. അതിൽ വരുന്നതാണ് ലെഫ്റ്റ് വെൻട്രിക്കുലർ ഹൈപ്പർട്രോഫി, അതുപോലെ റെഡ്യൂസ്ഡ് ഡയസ്റ്റോളിക് ടൈം, പിന്നെ കാൽഷ്യം ഓവർലോഡ്, അമൈലോയിഡോസിസ്, ഇൻക്രീസ്ഡ് ഇൻട്രാമയോകാർഡിയൽ പ്രഷർ, ഇൻക്രീസ്ഡ് ഇൻട്രാ കാവിറ്റേറ്ററി പ്രഷർ, ടിഷ്യൂ എഡിമ. സോ ദീസ് ആർ ദി മയോകാർഡിയൽ ഫാക്ടേഴ്സ്. അല്ലെങ്കിൽ കുറച്ചെങ്കിലും ഓർക്കുക, കാൽഷ്യം ഓവർലോഡ്, ലെഫ്റ്റ് വെൻട്രിക്കുലർ ഹൈപ്പർട്രോഫി, ടിഷ്യൂ എഡിമ, ഓക്കെ, ഇൻക്രീസ്ഡ് മയോകാർഡിയൽ പ്രഷർ, ഇൻട്രാ കാവിറ്റി പ്രഷർ, ഓക്കെ, ദീസ് ആർ ദി മയോകാർഡിയൽ ഫാക്ടേഴ്സ്. ആൻഡ് നെക്സ്റ്റ് ഈസ് എ ഫങ്ഷണൽ മെക്കാനിസംസിൽ എന്തൊക്കെ വരും? അതിനു മുമ്പ് ഈ ലെഫ്റ്റ് ഹൈപ്പർ വെൻട്രിക്കുലർ ഒക്കെ എങ്ങനെയാണ് അഫക്ട് ചെയ്യുന്നത്? ഇപ്പൊ ലെഫ്റ്റ് വെൻട്രിക്കുലർ ഹൈപ്പർട്രോഫി ഉണ്ടെങ്കിൽ ദിസ് ക്യാൻ കംപ്രസ് ദ മൈക്രോ സർക്കുലേഷൻ. ഓക്കെ, ദിസ് ക്യാൻ കംപ്രസ് ദ മൈക്രോ സർക്കുലേഷൻ ആൻഡ് ദിസ് വിൽ ലീഡ്സ് ടു ഡിക്രീസ് ഇൻ ദ ഡയസ്റ്റോളിക് ഫില്ലിംഗ്. ഓക്കെ, ഇപ്പൊ here these myocardial factors are indirectly they are resulting in the microvascular dysfunction ആണ്. Okay, so indirectly they are having an affection of the എന്താണ് vasculature. Okay, this will predispose to ischemia in case of myocardial factors. Okay, that's the left ventricular hypertrophy. And other than this we have the functional mechanisms too, like the microvascular spasm and abnormal vasodilatation also. Okay, so normally in exercise there is an increase in demand. We know that normally during exercise time there is an increase in demand. So this micro circulation like arteries will dilate for giving more blood supply at that time. Okay, so this will help to a better perfusion during the exercise time. So when there is abnormal vasodilatation, like functional mechanisms like abnormal vasodilatation occurs, this will not occur. Okay, during exercise that vasodilatation will not occur. Okay, thus the demand supply mismatch, there is a mismatch between the demand and supply occurs, and this leads to ischemic heart disease. Okay, so that's the functional mechanisms. So combining all that, we can say the myocardial ischemia. Okay, myocardial ischemia is mainly due to some critical coronary stenosis. Due to critical coronary stenosis, this will leads to atherosclerosis that leads to the critical coronary stenosis. That is one of the reason. Then another reason are this microvascular dysfunction. We said that the microvascular dysfunctions, then the inflammation, then endothelial dysfunction, vasospasm, and also the platelet and coagulation. Okay, so these are the main factors which are responsible for the MI. So study the critical coronary stenosis due to atherosclerosis, then microvascular dysfunctions, then endothelial dysfunction, inflammation, then platelets and coagulation, and vasospasm. Okay, so what happens during an endothelial injury? So whenever a atherosclerotic patient is predisposed to any endothelial injury, what happens? This endothelium, our endothelium will be converted to a prothrombotic agent. Okay, endothelium will be converted to a prothrombotic stage or agent. Okay? So when it becomes a prothrombotic agent, it leads to the formation of thrombus formation, and this leads to the occlusion of the artery, and this leads to ischemia. Okay, so normally our endothelium will produces antithrombotic agents, but during this endothelial injury time it will be converting into a prothrombotic agent. Okay, so this is happening in a atherosclerotic patient. Okay, so now we studied about the ischemic heart disease, like the mechanism of actions we studied here. So next is the about stable ischemic heart disease. Next we are going to study about the chronic stable angina or this stable ischemic heart disease. Okay, and this looks like a stable disease. Okay, this chronic stable angina means it looks like a stable disease. And it is more commonly seen in case of males. Okay, females ne kaalum males ilana idu കാണുന്നത്. Why? Because in case of females, before menopause we know that estrogen production is there. Okay, so this estrogen that gives a protection from forming the atherosclerosis and other coronary events. So estrogen is a protective agent from this coronary events. Okay, so therefore the males are more affected in case of stable angina. And what are the risk factors? Can you say what are the risk factors? The risk factors are, first one is age. As the age increases, there is more chance of atherosclerosis is there, and increases chance of like coronary diseases will increase as the age increases. Next is the obesity, then sedentary lifestyle, diabetes mellitus, systemic heart hypertension, and dyslipidemia. So these are the risk factors for chronic stable angina. Next is the pathophysiology while describing. Okay, so the chronic stable angina means it is a reversible ischemia. Here this ischemia that is happening is reversible. Okay, why here reversible means in acute coronary syndrome, it is not a reversible ischemia. There you have the plaque rupture or erosion happened in case of acute coronary syndrome. Okay, therefore that is a more fatal consequence in case of acute coronary syndrome. But the chronic stable angina, it is a reversible ischemia. Okay, so that's the pathophysiology. So next is the clinical features. In clinical features, in early stages the patient will be asymptomatic, and after that the patient will develop anginal episodes. Okay, the patient will develop anginal episodes, and anginal episodes means the patient will be having pain over the substernal. Okay, substernal pain will be there. Okay, and how we can characterize the pain? Okay, main characteristics of the pain are the pain will be like heaviness over the retrosternals or precordium. There will be like a heaviness, like okay, the pain will be like a heaviness or like a squeezing type of discomfort, but the patient will say that the pain is like a squeezing type of discomfort. Okay, and sometimes the patient will say like a pressure type of sensation over the substernal region, or pressure type of sensation over the substernal region. So like this the patient will describe the chest pain. Okay, and this chest pain only lasts for like 5 to 10 minutes. Okay, it will not last for more than 30 minutes. It only lasts for like 5 to 10 minutes only the chest pain will last. Okay, so that time only we will be securing the medical assistance. Okay, and next is how the okay, and this pain is crescendo decrescendo type of pain. That is, here this type of pain is increases. That is crescendo decrescendo type of pain. And here this pain, its severity varies. Okay, sometimes the pain like a severe pain, sometimes moderate intensity. So the intensity of the pain that varies in case of this chest pain. And sometimes the patient demonstrate the nature of this anginal chest pain, that is by means of a clenched fist over the precordium or the sternum. So, okay, he will put like a clenched fist. They will put the hand on over the precordium. Okay, so that's how that like that only the patient will demonstrate the chest pain. Okay, by putting the clenched fist over the precordium or sternum. Okay, and we call that sign as the Levin sign. Okay, we call that sign as Levin sign. Okay, and did this pain may radiate? Yes, the pain will radiate to the left arm. It radiate to left arm, mainly to the medial aspect of the left arm will be the pain will be radiating. Then also to the right arm, and also sometimes to the neck, jaw, and also to the interscapular region, epigastric region. Okay, so mainly it will be most commonly the pain will be radiating to the left arm medial aspect, and sometimes also to the right arm, neck, jaw, like that regions also. And this pain will worsen by doing exercises or some emotion conditions. This will be worsened. Okay, and also it is also not only by exercise and also by the meals like postprandial. So it is also called postprandial angina, and also due to cold and also after sexual intercourse. So these are worsened by these exercise emotions, like these conditions also. Okay, so these this chest pain that is precipitated by these exertions. Okay, and next this can be relieved by rest or taking nitrates. Okay, by giving nitrates the demand will decrease. Okay, therefore the supply becomes normal and thus the chest pain gets relieved. Okay, so it is worsened by exercise and relieved by the rest of nitrates. That's also a characteristics of this chest pain.